not, let me know. We'll reformat the whole class. I want to do what works best for y'all. That's another chart. If you want to take a picture of that, guys, to show you some examples of that assault versus battery. That's what the next few slides are talking about. That tells you how the legal system works as well. Like for assault, you get less than a year for a third degree, 1 to 25 years for a first and second degree assaults. There's different levels of assaults. For battery, you get probation for first offenses, up to a year for basic, several years for license for more severe battery cases. So what would be like a severe battery case? Like murder, child abuse, things like that. Sexual assault, things like that. Yes.
So it says there is actual harm or inoffensive action. Does inoffensive action also correlate with acts that don't involve pain or damage?
So like, I mean, as crazy as it sounds, let's say I lose balance and I fall on top of somebody and like I injure them. Like I fall on a child and I break their arm. I didn't do it intentionally, it was inoffensive, but it's still battery.
Okay, so that's what inoffensive is, like unintentional.
Mm-hmm.
Okay.
So in the green part that overlaps, what is that explaining?
That both can be led to criminal offenses. Both have lighter offenses that we call misdemeanors, and both can involve bodily harm. That's talking about mental.
Okay.
Mental harm falls under bodily harm. All right, just a couple more examples, guys. Assault versus battery, the false imprisonment or illegal detention. Assault, once again, imminent threat. Battery is the intentional, unconsented touching of another person, as we've been stating. False imprisonment is unjustifiable detention of a person without legal warrant within boundaries fixed by the defendant by an act of violation or duty intended to result in such confinement. Fancy way of saying that you're restraining somebody without their consent. Now, the one thing I want you to pay attention to, someone brought up this earlier, is the unjustifiable detention of a person without legal warrant. What would be legal warrant? That'd be your prisoners you're talking about. They have that legal warrantization to actually restrain criminals. They've already broken the law, thus they're not gonna fall under that jurisdiction anymore of the false imprisonment. Make sense? But if I get mad at the patient and I tie their arms down without permission of the patient or the parents, then of course it's gonna be false imprisonment. Another word for it can be illegal detention. So another one of those words that you wanna write down. Alternate way of saying false imprisonment is illegal detention. Mm-hmm.
Can you give us a question on how or how not to define legal warrant? Like court ordered or other than just prisoner? Like how would the test pose that?
I mean, I don't think they're gonna ask you on that. It's just good to know that if we're talking about a prisoner, they've already broken the law, they're not gonna fall under the unjustifiable detention of a legal warrant because the police have the right to handcuff them because they've already broken the legal boundaries. They're not gonna ask you that much detail on that.
Okay.
Hang in there, guys. I know it's a lot. I know we're maxing out on our lecture attention spans.
And to confirm, battery can be unintentional and
Yes.
Okay.
It depends on how the person accuses you. It really comes to the accusation, which is why.
Of how they accuse you or what they accuse you of?
How and what?
Okay.
They can say you intended it, but it may have been a complete accident. But from their point of view, it was intentional.
Mm-hmm.
So they're still going to accuse you of battery. So for battery to be an actual legal issue, it has to be intentional. When I say unintentional, I mean it can be unintentionally. You can be unintentionally accused of it because it was an accident. But you can defend against that, of course. I fall on somebody because I tripped. I didn't do it on purpose. It was an accident. But from their point of view, they might think I did it on purpose, so they're going to legally accuse me of battery. But I have witnesses saying, hey, no, John Donahue tripped and fell on that patient. It was not an intentional act.
I still feel like that's pretty extreme though. Like let's say patient comes in, trauma shoulder, and your marker falls on their shoulder. Like
they might accuse you of battery, but you can defend against something that's silly. And that's probably gonna be dismissed anyway. But from their legal rights, they can say, hey, Jay the tech set me up with that marker. That was
Yeah.
a setup.
Yeah.
You get those
He
conspiracy
knew it
people.
wasn't
That
sticky.
was a setup.
He did.
They had this all figured out before I walked in. It was a whole setup to get me injured. You've heard people talk like that. Bunch of conspiracy people. It can happen. There you go. Picture to help you. So threatening to hit, but not actually hitting me. So keep in mind, assault can be physical but not touch. I can threaten to hit somebody with a hand motion and not actually hit them, and that's assault.
Mr. Donahue.
Like I pick my book up, it's like, like, you know, towards somebody, and I make sure he flinch. It's like, oh, that's assault. That's assault. I want you to keep that in mind, that that can also fall under assault. I can raise my hand, I can raise a weapon. Like if I have a knife and say, I'm gonna stab you, and you flinch, but I don't actually stab you, that's assault. But if I take that knife and actually stab you with it, then we have the battery. Does that make more sense now? But you see how there's a lot of those overlaps too. You gotta be really clear of what you're reading in the question, of what's actually happening in the scenario.
Let's say a patient is assaulting or doing the most and causing damage to our stuff. We leave the room, but the tech tells us to go back in. How do we just say no, I'm not doing it, or what?
You have the right to refuse.
Okay.
If you're uncomfortable, you have the right to refuse to do a patient, and you just call the correct people and say you're not comfortable doing it. They'll either send somebody else, they'll diffuse the situation, whatever.
Okay.
But you do have that right. I've refused to do patients. I've refused to do patients on children that just, it doesn't matter, unless the hand of God came down and restrained that kid, there was no way I was going to get that exam. I have the right to refuse to do so because I'm not going to expose that patient knowing that it's not going to turn out anyway.
Right.
I'm like, unless I have the proper assistance to have that child be still, I'm not doing this exam. Because it's just going to be a waste of time and it's going to overexpose the patient. But you see how I explain that?
Mm-hmm.
I'm not just saying I'm not going to do it. I gave a valid explanation as to why. I don't want to overexpose the patient. I don't want to x-ray them needlessly. And if I don't have actual help, that's what's going to happen.
Right.
So until I get that, I'm not going to proceed with the exam.
So it's all about the wording then.
It's all about the wording, the communication. All right, negligence, once again, guys. I know I'm repeating a lot of these, but I want you to see these definitions in different forms. Failure to provide a level of patient care that a physician with ordinary prudence would have in the same situation. Fancy way of saying negligence equals neglect. You're not paying attention. You make a mistake doing the wrong order. The patient rolls off the table. They fall off a chair. That could all fall under negligence because you're not paying attention to the details. You're not aware of the whole situation. Negligence can be accidental as well. You might be in the room and a patient falls out of a chair. They can accuse you of negligence, even though you weren't quick enough to help them. But from their point of view, you should have been paying attention to them the whole time and right there to respond. It all depends on how they accuse you of that tort. But you can defend against said torts with your own documentation. Of course, having witnesses is always a big plus as well. Because my text should never really work alone if you can help it. You should always have someone with you if you can help it. It's really going to help you out.
So what about like if they hit themselves?
If they hit themselves?
Yeah, like
Like
the
they
other
batter
day,
themselves?
like the other day I was doing a knee exam and I moved the machine out of the way, and when she was walking, she like was like this close to bonking her head. Like her head almost hit it, but if she would have hit it, even though I moved it out of the way, would I still get in trouble? 'Cause
She
I
could
didn't
accuse
move
you
it
of negligence, yes.
Because
But,
I didn't move it enough.
huh?
Because I didn't move it enough.
You didn't move it enough.
That's weird.
I'm telling you guys, people can accuse you of anything these days. But I don't want that to scare you because as long as you're crossing your T's, dotting your I's, documenting everything you do, you're going to be okay. You just want a paper trail to everything you do. I cannot say enough that there is power in taking the time to document everything you do. There really is.
Still hit.
All right, guys, example question here. Kind of simple to start with. A caregiver walks into a patient's room without knocking. This is an example of what? The only one that makes sense is invasion of privacy. Yes. The nurse gives a patient who is competent. The nurse gives a patient who is competent. We're not wording it well. To make decisions for himself, a bath after.
What?
This is terrible, right?
Battery.
This is an example.
Battery.
The nurse gives a patient who is competent. Let me try to reword this. The nurse allows a patient who is competent to make decisions for himself after he refused a bath.
Bad.
Basically, she gives him a bath after he said he
battery.
refused.
Yep.
Battery be battery.
I'm going with bad.
Okay, wow, this thing is like screwing my brain up. Patient refused a bath, a nurse does it anyway. What would that be? Battery. There we go. That's probably what it should be saying. If they had threatened the patient without actually doing it, though, it'd be what? Assault.
Sometimes they'll do it nice.
They give you a bath.
They won't threaten them like
We
direct.
already went over that. All right, a few more legal theories, guys. These are the two that people often mess up.
Oh,
Those two Latin terminologies that I know we also love. Res ipsa loquitur, the thing speaks for itself. What's an example? Patient is injured through no fault of their own while in complete control of another. You might give an example of that in an actual scenario.
would that be nice?
Be kind of like the one you're just talking about. But there's still some overlap. They can accuse you of negligence, but really, the thing spoke for itself. Patient wasn't paying attention and they ran into the equipment. Or let's say patient walked in the room, they weren't paying attention to their surroundings, they stubbed their shin on the chair. It speaks for itself. They did it. It's
Yeah, the
loquitur.
chair's
The
where it's
thing
supposed
literally
to be.
speaks for itself.
I didn't like take
Can it-
Basically, this would be the most common way this would be used would be injuries that occur due to the patient's own fault. Or a patient comes in with an arm fracture. I can see there's an arm fracture. It speaks for itself. It's res ipsa loquitur. It's speaking for itself because I can visualize that I see an arm fracture. Patient fell off the table because they were acting crazy. Kids going nuts, parents not helping. Kid jumps off the table, busts their head. It spoke for itself, res ipsa loquitur.
I have another example of that.
But this, I'll come back to you. But respondent superior, the master speaks for the servant. Basically, if I cause the harm or the physician caused the harm, so not only is the individual liable, but the physician and healthcare facility are as well. So same issue. Kids jumping on the table. I run over, say, Mom, can you control the kid? What are you doing? I throw my arm like this, and I hit the kid goes flying off the table. I caused the injury. That's my fault. Thus, it's the hospital's fault. So the master speaks for the servant. That's respondent superior. So simplest breakdown I can give you guys is res ipsa loquitur is things that you can easily visualize that are self-explanatory, like injuries. But also, when we're talking about like legal aspects of patient harm, the patient harms themselves. Whereas respondent superior is if I am the cause of the injury or the whatever situation is going on. It's my fault. I did the wrong exam. Therefore, I'm at fault. Thus, the hospital's at fault. That's going to be respondent superior. Making a little more sense?
Why does it say no fault of their own?
Yeah, that's what I'm confused
I
on.
thought res ipsa loquitur was,
It's accidental injuries.
But-
Accidental injuries. Like, once again, maybe patients not paying attention, they come in and they stub their toe on the table. I mean, they didn't do it intentionally, but they got hurt.
But they're not in complete control of
They
it.
got into a car wreck. It was not their fault. It was someone else's fault. They come in with a busted up arm. I see there's a busted arm. It's speaking for itself, but it was not their fault. It's res ipsa loquitur.
another person's fault.
That's-
That's the respondent superior. When someone else causes it, namely in a hospital setting when it's the actual caregiver.
So Mr. Plummer gave an example of like, x-raying the wrong part, but I don't know if it was res ipsa or.
X-raying the wrong part would be respondent superior because that's my fault. That's not the patient's unintentional misconduct or whatever. That's me directly making a bad decision. My fault, thus it goes to be the hospital's fault. It's me respondent superior.
I had a patient one time, she was an older patient, and her skin was really thin, you know, when you can like pick it up. So she got on the table, and when she was like moving herself, I guess her skin kind of like caught itself and it
Ooh.
ripped, and she
Ooh.
started bleeding. And so I was at Strawberry when that happened, and she was like, I don't have any Band-Aids here, this doesn't happen. But that would have been her fault.
Unintentionally her fault. So that would be res ipsa loquitur.
Yeah, because she was just getting on.
It was accidental.
Yeah.
Although she caused it, you can see that it happened. It's speaking for itself. Res ipsa loquitur.
But the
Well,
patient
what
was
about-
in control of themselves, though.
Mhm.
So they wouldn't be in control of the tech, another subject.
It's still going to fall under that categorization. If we're going to categorize it between those two, we have more Latin terms than this, by the way. I'm not gonna confuse you by going through those, because these are the only two you're gonna be asked about. So we can get super technical, Jay, but that's just gonna confuse the class. So I'm gonna leave it at these two because these are the only two you need to know. So basically, in simplest of terms, without overthinking it, accidental injury to self versus we cause the injury. That's the easiest breakdown of those two terms. Yes.
Sophie, what do you mean by violating the complete control of another?
Don't worry. Don't overthink that. Don't worry about that. So
This is
I don't want you to overthink that. I want you to basically just focus on patient accidentally causes injury to self at no fault of their own.
and no fault of their own meaning?
No fault of their own. That's what an accident is.
So what
If
would
I
be-
walk over here and I trip on my shoelaces and I fracture my knee, I didn't do it intentionally. It was an accident. I tripped on my own feet. But that's going to fall under res ipsa loquitur. Y'all can see that I broke my leg as well. It's very visual. That also falls under res ipsa loquitur. It's an accident. It wasn't intentional. But if I walk by you, Shaheen, and you stick your leg out and you trip me, and I go and bust my knee, now what's it fall under? Respondent superior because you caused that injury. That's the simplest way you can remember that. No more complicated than that. Yes.
What would the tort be, or the corresponding torts be
For
those?
so
Negligence,
for this
battery?
one, for the first one, it could fall under negligence if they
Okay.
wanted to go that route.
Okay.
This one most often will fall under battery.
Okay.
Not always, but most commonly. Now, there's another term you need to know, guys, corporate liability. And speaking of speaks for itself, I think that speaks for itself as well. What does corporate liability mean? The corporation is liable for what occurred. So, healthcare facility responsible for employees and contractors, including physicians. That means no matter what happens here, ultimately it's the corporation that's in control. They're the ones that fall liable, even though you might lose your job, they are ultimately liable. Duty of reasonable care in selecting retained employees and staff falls under corporate liability. Duty of reasonable care and maintenance of equipment also falls under corporate liability. So if there's an issue with one of the rooms, like it blows up or messes up or the tube falls on somebody's head, corporate liability, they're responsible for that. And availability of equipment and services. You go into a hospital and they don't have the best equipment, patient complains about it, corporate liability. All four of those scenarios fall under the corporate liability. Does that make sense? That's not stuff we can control, it's stuff that falls under the business, the actual company itself.
I hope the next slide says
It's a long class, I know. Let's go over a little more consent, guys, because you gotta know the difference between these two. Make sure you know the difference between implied versus informed consent. Implied consent is the most common form of consent in medical imaging, not hospital. In medical imaging specifically. Please write that down. It does not require a signed statement of consent. That's the majority of the procedures you do, guys. It falls under implied. Majority of what you do in X-ray falls under implied. But even such, patient can still have the right to refuse said procedure, no matter what. They can still decide at the last minute, I don't want this X-ray. And you cannot take that X-ray if they state that. They can have one view done and still refuse it. And you have to stop it right there. Yes, Jay?
So would a question on that be, what is the most common form of implied consent?
Just what's the most common form of consent within medical imaging? It'd be implied.
Okay. So it wouldn't be like showing up for the exam is the most common. Okay.
They're gonna be specific on that. Now, what is informed consent? That's what we have for any type of invasive procedure, anything that has a venipuncture, surgical, whatever. Even our barium studies are considered invasive. Why? Because we're drinking barium. It's going inside the body. Thus, we must explain in full detail the risks, what's going on, and what's going to happen with that procedure. We got to go to the benefits, the risks, the alternatives. Must all be explained. And for all of these, you must have a signed statement of consent that is required. Now, this does vary per facility. Some facilities do not require signed consents for some of these procedures, but the majority do, and the majority should. So per the curriculum, anything that's considered invasive will need that signature of the patient. It must be informed consent. So implied does not require signatures. Informed does require signatures. Which, think about it. If I'm informing somebody of something, it's just like any kind of thing you sign in your life. You want to know what you're signing. You've got to be informed of what you're signing. I'm not just going to say, here, sign this, and not tell them what's going on. And if someone signs that, they shouldn't. That needs to be told to me. What am I signing? That's the nature of an informed consent. I'm informing them of what's coming before they sign it. Make sense? Yes.
So in CT and MRI, you said they do the looking at picture.
That would be invasive.
Who gets that consent? Like the we do or the nurses? That would be
So typically they'll sign that before the procedure, like with the front desk or things
Oh,
like
okay.
that. Yeah. Yeah, they'll be scanned into the system.
Would you also have to get consent before doing the flush? Like, hey, I'm about to give you the saline.
Well, you
flush.
should, I mean, that, like I said, that'll all be taken care of before they even come back there. So that's all covered on that consent
But
form. that
even
they're doing.
even if they've already signed it, you don't have to tell them like this is what I'm about to do. You should just.
I mean, I would still anyway, but typically in most facilities, it's already in their contract that they're studying, I mean, that they're signing. So it's all included on there. Whether they read it or not, they probably don't, let's be honest, because how many of you read the fine print on anything? Most of us don't really. So it doesn't hurt to re-explain it as a tech, because most people aren't going to pay attention to that stuff anyway. Or they're so nervous they didn't even know what they were reading.
Right.
Yeah.
But it gives them right, a picture.
These parts here, guys, are really good to know if you want to take a picture of that or write it down. There are parts of informed consent that must be included. There must be what we call an authorization clause, allowing the provider to perform the actual examination. There must be a disclosure that explains the benefits, risks, and alternatives to the exam. And most of you that have had procedures know exactly what we're talking about here. You always have that long list of stuff that can happen to you, plus here's the alternatives to the procedure. It's all required. If there's anesthesia, there must be a clause of that as well, of the benefits versus risks. A no guarantee clause for therapeutic procedures. Tissue disposal clause if removal of tissue is necessary. A patient understanding clause. Sign here if you understand all the risks and benefits and you want to continue with the exam. That's usually the very end. And a signature clause for both the patient and a witness who will not participate in the procedure. Typically, you always want to have a witness sign that stuff with you. That's just to solidify the legalness of the document. It's always good to have a witness with you. Not
The
all,
witness-
you won't always have a witness, but typically they prefer if you sign with a witness.
The witness with the healthcare side or the patient side?
It could be either way.
Okay.
Now, a lot of this stuff, as far as you guys go, you say, well, where do I sign this? I've never seen anybody I work with sign anything. A lot of this stuff you sign in Epic. So when you end your orders in Epic, you're going to be signing off on these clauses with your initials and the date. Make sense? A lot of this stuff is digitized now. Almost done, guys. Hang with me. I'm getting hungry too. I can tell half the class is just so done, so over all this talking.
How do you?
If y'all could ever see what I see,
How do you do this like every year?
how do I do it?
Yeah,
Because I enjoy it.
Oh my God.
I like filling minds with knowledge.
So you have to. This ain't for the week.
Yeah, cause I can't do it.
All right, big one here. Y'all all commented a lot on contrast reactions. These are extremely important to know, guys. And we'll probably finish up these on Thursday because I'm almost out of time. But big one, what's the worst thing that can happen? That extravasation. What is it? The leakage of contrast outside the vessel. How's that occur? Well, most commonly, if the nurse is really bad at venipuncture, they either won't advance the needle enough, so they're just not even in the vein, or they go too far and they puncture straight through the vein. So obviously when the contrast starts flowing, it's not going into the bloodstream, it's going through all the tissue outside the vessels. And it causes an actual ballooning like you see on this child's hand here. Very painful, very uncomfortable as you can imagine. Also, if a vein explodes, that can happen. Which is also why, as a tech, guys, especially if you go into CT and MRI, I don't care what that nurse says, you should always flush that vein. Because you're double checking to make sure that this is not going to occur. Because big issue, I mean, imagine they've had half that CT done, they've got all this dose, and all of a sudden that extravasation occurs because the contrast is going in the wrong spot. You're having to stop the procedure, tend to the patient, and then restart that whole exam again, frying the patient even more. And CTs are a barbecue, man. That's some high dose. You are barbecuing your patients. So if this does happen, what's the order of treatment? Know this 3-step process. Of course, inform radiologist / call for help, just like an emergency response. You elevate the extremity, very important. And then you're going to apply hot and cold compress. And where they get people is they'll use one or the other. They'll say hot compress or cold compress. You want both. You alternate both to reduce the swelling. That's where I see people miss that question the most. You're alternating hot and cold compress.
And if you elevate the arm so it can float out.
Yes. Because you need the body to kind of flush that all out.
So this can be avoided with the saline first.
That's one of the main reasons you do saline flushes, to keep this from occurring. Make sure that needle's in the right spot.
So the saline wouldn't do that?
Well, that's the wonder of the saline. It's not going to hurt as bad, but they'll feel some discomfort with the saline. They're like, hey, something's going on. That tells you, stop, we need to go check that vein out. Something's not right.
And he said something like it's going to come back, the saline, when you're putting it, it won't.
Or it might, you're right, that's correct, or it might not even go in it at all.
Oh, yeah.
You'll feel resistance, which is a big, please, let me tell you guys, because y'all rotate through these areas, if you go to inject that saline and you're getting resistance, please do not force that. Please, for the love of God, do not force that in. Like you're gonna blow the vein up. That hurts even worse than extravasation. Don't explode the veins. My poor wife has had many exploded veins, and it's very painful because people get impatient or just not doing what they're supposed to be doing. Yeah, don't do that. Guys, big, mega big, ultra big. This will be the last slide I go over today. Superstar. I should have put a star there. Super gold star. What are our contrast reactions? We have 3 types: mild, moderate, severe. There is slight overlap in the conditions, but you need to know how to pick out what is mild, what is moderate, and what is severe based on these signs that will occur. For mild, scattered hives. What's pruritus?
Inflammation or something?
It's swelling. Swelling. Rhinorrhea. Does it have to do with rhinos? What's a rhinorrhea?
No. No. Yeah, nose.
Your nose starts running, basically. Like diarrhea of the nose. Rhinorrhea.
Lovely.
In fact, I always figure the person that came up with that word, which is really cruel, because you know, people that get nose jobs, it's called rhinoplasty. So you're like already insulting the poor person even further, saying you're getting a rhinoplasty because you guess your nose looks like a rhino.
That's
Isn't
a
that
good way to
kind of
remember
further
it, though.
insult to injury?
That's kind of funny.
Like who thought rhino was appropriate? I don't know. That's a bad joke, but
It's a good way to remember it.
rhinorrhea. Now you won't forget it, right?
Yeah.
Rhinorrhea, diarrhea of the nose. That's how I remember it. Rhino refers to nose. Rhea means flow. Coughing. Coughing is another mild reaction. How do we monitor mild reactions? We monitor them for 20 to 30 minutes, and we're going to monitor their vital signs and give them an antihistamine if needed. That's going to be the appropriate response for a mild reaction. Moderate. Diffuse hives. What's the difference between scattered and diffuse hives? Basically, it's a fancy way of saying the hives get worse. So a lot of times it'll start as mild, but it will progress. I see the hives getting more increased. They're becoming diffuse. That tells me they've moved on to moderate reactions. Vomiting, laryngeal edema, and tachycardia. That pulse rate's going to increase. So for this one, we're going to continue to monitor, check the vital signs. We're not going to continue the procedure, by the way. We're going to monitor them until it improves. Check the IV access. A lot of times these reactions occur because of bad IV access, and we're still going to administer antihistamines. Cody, I saw your hand go up.
When I was in MRI, we had a patient who did start to vomit after they injected the contrast. So they did stop and they got her the bag and everything. But it wasn't, I mean, she stopped very quickly. So like, would you say, is that a mild reaction?
Vomiting's moderate.
Oh, okay.
Vomiting's always moderate.
Even,
Yeah.
Even if it's under like claustrophobia or something like that?
It would still fall under moderate, yeah. Why? Because it's a little more dangerous than mild because they can do what?
They can
with
choke on
vomiting?
it.
They can choke on it. So it's a little more serious. Now, with that in mind, guys, keep in mind, mild and moderate are not life-threatening. We don't want them, but they're not life-threatening. It does not become life-threatening until we get to the severe category, and that's when we're talking about altered mental status, pulmonary edemas, laryngeal edemas, life-threatening tachycardia, and of course, death. I think it's pretty severe if they die on the table. What's the response, guys? Call for help, call a code blue, someone will administer epinephrine immediately. That's the response for a severe contrast reaction. Please know how to identify the different conditions and what category they fall under. That's something they've been commonly asking. When it comes to the type of pharmacology things you can expect, does it fall under the pharmacology stuff in patient care? Contrast reactions, because contrast are medications. Keep that in mind. Contrast are medications. Question?
What's code blue and epinephrine?
What's code blue? We need to restart school if you don't know what code blue is.
Sorry, I didn't go to school in America.
You took CPR, did you not?
Oh, I see. You mean that awful. I don't remember. Sorry.
What's code blue, everybody?
A serious situation.
Extreme
life
serious.
threatening.
Serious life-threatening situation, we call it code blue. That's the emergency response system. Emergency response, we're gonna call it code blue. Please don't forget that. That's an important one.
Code blue is an emergency response system.
Yes.
So for the tachycardia, it says life threatening. Is that like AFib or like?
That would be your actual arrhythmias occurring, yes.
And
So
you see it-
keep in mind, tachycardia can occur but not be life-threatening.
Right.
I can have a fast pulse rate, but I can calm that down. I might just be hyperventilating.
Right.
That's tachycardia. But we're going to actually like atrial fibrillation, quivering heart, actual arrhythmias. That's going to be the life-threatening tachycardias.
So would we see that through the monitor of like the EKG?
You
or-
would, yes. Yes. All right, guys. The front row. I've lost the front row. They're all. They're having severe contrast reactions over here. Severe lecture reactions. So we're going to end on this slide today, guys. And you are dismissed for lunch. We'll
y'all
wrap
should
up
do
the
that
rest of
more
this.
often.
Check it out.
Yeah, do that more often.
Thank you, guys.